All right, we'll get started now. Welcome to this very interesting panel discussion on the impact of recent cuts on the HIV response in Asia. My name is Professor Sharon Lewin. I'm the Director of the Doherty Institute, a joint venture of the University of Melbourne and Royal Melbourne Hospital in Melbourne, Australia. And I'm the previous President of the International AIDS Society from 2022 to 2024. So very familiar with what's happening on the global stage with funding and the response to HIV. We've got quite a nice sized audience here, and if you would like to come further up to the front of the room, please feel free to do so, and that will allow us to have a nice conversation. If you want to sit up the front but still look at your phone or check your laptop, it's all fine. But if you want to come up to the front, that would be great. I love Bangkok and love visiting Thailand. I've worked for many years together, collaborating with HIV-NAT, primarily with Dr. Anshali, and previous to that, Dr. Kiat, primarily working on HIV, hepatitis B co-infection. So always wonderful to be here. Unfortunately, 2025 has been a time of great upheaval, disruption and anxiety in global health, and also the HIV response. So all of us have experienced some very significant changes. For many years, there's no doubt that the world benefited from the leadership and also the generosity of the US government through their support of PEPFAR, the WHO, the Global Fund, and of course, the National Institutes for Allergy and Infectious Disease. But in January 2025, I think much to all our horror, things have changed in ways that none of us imagined was possible. The dismantling of USAID, reduction in PEPFAR, cancellation of grants, unacceptable narratives around transgender people and other key populations, and an erosion in the value of evidence-based decision-making for public health. And these are just the few things that we have all witnessed and experienced in under 12 months of the current US administration. So we don't know what is left to come in the ensuing 3 years. And so these changes have had wide-ranging impacts across the world, particularly in the HIV response, which has been specifically targeted, and here, of course, in the Asia-Pacific region. Now, the US is not the only funder of international health. The UK, France, other countries in Europe have also, and Australia too, have also been significant funders, and they too are seeing reductions in commitment to overseas development. So we're working in a very challenging environment. So today we have 5 outstanding leaders from across the Asia-Pacific who will talk to us about what has changed, what have been the impacts locally, but also, just as important, how this seismic change could be an opportunity to rethink the framework for global health. A close colleague of mine that many of you might know, Mitchell Warren, the CEO of AVAC, recently said that the changes in global health that we've seen in 2025 are like a major earthquake damaging the homes we live in. So we need to rebuild, and we need to rebuild better, a type of house that will be more resilient and can weather similar future disruptions. So whether you're a glass half full or a glass half empty person, perhaps all this change will lead to some positive new developments in our approach to global health and the HIV response. So before we hear from our panel, I'm going to introduce each of them to you. And then I'm going to ask them to tell us a little bit about what's changed in their specific disciplines, and they all work across different areas, what the cuts to international funding has meant for their work, and particularly in the real world on the front line in which many of them work, and also to reflect on whether there may be any opportunities through the darkness that we have all felt over 2025. So immediately to my left is Dr. Raina Tan. Raina is an assistant professor and leads the Courage Lab at the Saw Si Hock School of Public Health, National University of Singapore. He is also an affiliate of the Centre for Behavioural and Implementation Science Interventions and Research Associate at the Centre for Family and Population Research at National University of Singapore. He's an implementation and socio-behavioural scientist whose work spans areas of stigma and health, community engagement and health equity. So welcome to Raina. Our next guest here on the panel is Reena Jamanesuk. Reena is Program Manager for Implementation Science at the Institute of HIV Research and Innovation, or IRI, here in Bangkok, Thailand. She's a leading expert in transgender health and HIV implementation science in Asia. She co-established the Tangerine Clinic, an amazing place that you should all try and visit while you're here in Bangkok. The first transgender-led, integrated, gender-affirming and sexual health clinic in Asia, which serves as a platform for service delivery, innovation and research. Her work focuses on community-led HIV prevention, including differentiated PrEP delivery, long-acting HIV prevention technologies, and stigma and discrimination reduction in health systems. So welcome to Reena. Our next panellist is Maria Tarcella Glur, and Maria is an adult infectious diseases specialist at Makati Medical Center in the Philippines. She's been in clinical practice since 2005 and is currently the chief of the section of infectious diseases. And her work has focused on treatment and research of tuberculosis and multi-drug resistant TB. And over the past decade has expanded to include HIV care as the epidemic has grown in the Philippines. She's had long-standing collaborations across the US, including with Georgia University and Emory, and leads an ACTG site that conducts clinical trials in the Philippines. So welcome to Maria. Next we have Charlie Witzel. Charles is a Principal Research Fellow at UCL in the Institute for Global Health and the Mahidol Centre of Excellence in Health, Behaviour and Society here in Thailand. He leads a program of research examining sexualised drug use among gay, bisexual and other men who have sex with men in Thailand. His work bridges implementation science, qualitative inquiry and co-production to address health inequities in substance use, mental and sexual health. And then our final guest is Dan Rosadio, and Dan is from Love Yourself in the Philippines. All of our panellists, I had access to quite significant bios. I didn't have that for Dan, but he needs no introduction because I know he's very well known across the region, doing outstanding research with a community-led organisation in HIV prevention, treatment and care in the Philippines. So please join me in welcoming all of our panellists. Now that was a very long introduction, so I'm going to get back to what I'd like our panellists to talk about in their first 5 minutes each, and that is how have these recent funding cuts from the US or from other sources impacted their work on the ground in the HIV response to Asia? What have been the real world impacts, the impacts on people that they look after? And could some of this be an opportunity for the future? So I'll hand over to Raina to start.
Thanks so much, Sharon. Thank you so much for the privilege to be on this panel and to have me here among all these esteemed colleagues over here. And maybe I'll make this brief, but one thing that I ask myself, is to think about my positionality. I admittedly, in the work that I do, while I run maybe some community-based work in Singapore, Singapore admittedly is a well-resourced setting. When the funding cuts came, it wasn't a matter of, let's say, life or death, where I'm at. which made me think deeper about, why am I here, right? So I think, and maybe as I thought about that earlier today, I do realize that there have been a few impacts of the funding cuts, not just on the community level, but also at a higher policy as well as the level of science as well, right? I think traditionally, and my position from Singapore has always been, I grew up feeling so inspired by all the community work that's around me. From around Singapore, because we don't get external funding. Funding comes domestically, and therefore the government only funds what it wants to, right? And that means a lot of the lack of innovation. Things that are safe, and that's where I grew up seeing all these things around, like key population-led services, community-led monitoring, things that empower communities. But also, I bet a lot of these things came from funders that are outside of your own countries as well. And I think one thing that it's so important with that is that when services are top-down, and this is something that I've heard over the last, today even, that the way we define health, the way we define prevention comes from a more biomedical model. And with community-led kind of work, communities can identify things that are just beyond that, what people need, person-centered care, differentiated care services. And what I fear is that when communities are lacking the infrastructure right now, all these programs are gone, actually what we know about prevention and what we know works is going to disappear as well. Right? I think the knowledge generation is going to shift its power back towards being more biomedical. And where is the force, the driving force towards having more community-led perspectives towards things? And I think maybe one thing that was involved in a little bit was also doing some facilitation for capacity building around chemsex in the region. And I think after a couple of rounds, that stopped, right? And I believe that's something that also highlights, like, areas that potentially are difficult for domestic funders and governments to touch on, that we might be losing traction on. So I think the knowledge generation bit is something that I'm concerned about, and it's also impacted the science and the research in the region as well. And I think more fundamentally, it changes the way we see what's important. And I think that is something that is a potential long-term impact. The second thing also is, I know with like a regional, like, UNAIDS, like downsizing and, restructuring things, I think UNAIDS has played such a big broker role in the region. I think I've seen them play a role that has bridged governments and communities, bridged governments to governments, and, I wonder what kind of impact that will have, in terms of this, knowledge generation, identifying what's important, and actually getting to the heart of the matter in terms of HIV prevention and treatment and saving lives. Should I touch on opportunities now, or maybe like?
Maybe we'll do the sorry. Maybe we'll do the opportunities later, so that we'll hear a bit from each person on the real issues. And I think, thank you, Raymond. You've highlighted the really disproportionate impact on community-led programs, which I didn't highlight earlier, and therefore changing the way we might address what we think is important, and that's been a big shift. So, Rena.
Yes, thank you. First of all, I would like to thank Prof. Sharon for your kind introduction, and another sincere appreciation goes to the organizing committee for giving me this opportunity to share our experience. So to respond to your first question, how the US funding cut has impacted our work here in Thailand. So I would like to share my own personal experience working at the Institute of HIV Research and Innovation, or HRI. So I have to share that, more than half of the organization's funding, actually, in the past 10 years, we rely on the US government funding. So almost half of these actually came from the USAID, and the remaining portion also came from the US NIH grant. So when our grants and projects were terminated, it's really caused a lot of negative impact to not only to the research projects, but also for the program implementation, and it's also leading to limited access to healthcare services, and especially for key populations, including transgender communities. And as Sharon mentioned about the Tangerine Clinic, which is a transgender-specific clinic established by the US funding back in 2015, and now we were terminated or closed down by the US, executive order as well. So I think what the impact that we experience is that you know that Thailand has been very good in terms of working on HIV, and ART and PrEP has been supported to everyone, as the citizen in Thailand. However, as you know that trans people especially, they do not want to come for HIV testing or even to get PrEP without other integration of gender affirming care. So when the US funding cuts, they withdraw the funding for gender affirming care, especially for the laboratory testing that they normally provided, because before they believed that gender affirming care has been used as an entry point services to generate demands among transgender communities. So when they come for gender affirming care services, the healthcare provider would offer or would lead them to other HIV and sexual health services. But then when the gender affirming care and other community-led efforts were disappear, those trans people, they were quite reluctant because they have to pay for the gender affirming care services from their own pocket. And especially if you are a transgender individual, you might be reluctant to pay for the transportation to come from another side of Bangkok to come to the city, and then you have to pay for the lab costs, for the hormone treatment out of your own pocket. I think they feel like, these services is not friendly for them anymore, and it's also resulted in service retention, including PrEP refills, including the new identification of newly HIV diagnosis cases as well. So I would say that in terms of service implementation, it's really caused the negative impact. And in terms of research also, because most of the research at IHRI that we normally did is also related to the issues that the society always having controversial aspect. For example, we work for trans people. We work on research on sexualized drug use or chemsex. We work for sex workers in order to bring the innovation to the community. But all of these have been terminated as well. So right now, I would say that we did not receive any fundings, but we only have 1 or 2 studies ongoing and still being supported by the US NIH grant. However, we have to change the research title. So it's out of record. You don't share to the US government. I know that's the local US government here, but I know that at the bottom of your heart, you're also supporting my work as a transgender community, right? But we have to do it indirectly in order to stay away from the AI detection system. If your research project is working for trans, they have to change to something else in order to avoid the detection of the system. I know that many US or American staff or people, they're still supporting us or our work, but they have no choice. They can't do anything. So I stop here and I will tell you later how we have addressed these concerns by using the data to advocate for policy change in Thailand.
Great, thank you, Rena. Maria. Yeah.
Hi. So as an ACTG site, and we're basically a clinical trial site. No, when the funding disruption happened, we had 3 trials with several patients enrolled. So of course the patients especially in low and middle income countries are dependent on the trial support for safety, for support of the staff. So what was affected greatly was the patient continuity in the trial, the safety follow-ups, the site governance. So we had to have a lot of communication with the participants because we had to increase trial support, we had to decrease trial support, decrease transportation. For one trial, we had to convert to telephonic follow-up, which would sacrifice science. So basically, of course, the staffing had to be decreased. We had to, for them to be maintained, they had to accept for pay cuts so that we cannot remove. So the trial capacity has also been affected. Although it was just a disruption and uncertainty, we eventually were able to get the funds at the edge of the, just at the end of the year, fiscal year. But it still was, and still the uncertainty in the future is still there. So the trial capacity in the region or in the country, because unfortunately, support for clinical trials domestically is not yet, it's not there yet. So we're dependent on external support for clinical trials, and we had to actually lobby with the CROs for industry trials to maintain our sites, for our site sustainability and to maintain capacity. So that's basically the impact on clinical trials is patient continuity, safety, and the science in general, and of course, trial capacity.
Great, thanks, Maria. Charles?
Yep. So I'd like to just reflect on the experience of reductions in overseas development funding from other high-income countries. So Canada, the country I'm from, and the UK, the country that I get most of my funding from, have both reduced what they call overseas development aid quite substantially. In the UK, it went from, there was a commitment from long-standing successive governments to keep ODA at 0.7% of GDP. That was reduced in either 2020 or 2021 or 2022 by the then conservative government to 0.5%. And then last year, 2024 or 25, the Labour government then reduced that again to 0.3% of GDP. So that's really reduced the amount of funding that can be provided. And of course, governments before that in the UK did all sorts of things like paying for domestic programs out of the aid budget, but it was a pretty serious commitment in general to keep it around 0.7%. Because of that reduction, more than 50%, having a career in global health has become much more precarious. So I'm funded by the Wellcome Trust, which is, thank you to the Wellcome Trust, they're really great and generous with funding and happy to do overseas development work, but they're now one of our main funders in the UK who will fund the type of work that we'd like to do. In terms of the career pipeline, there's a big gap now for global health researchers from the UK trying to move into independent positions because our main global development sort of bridging gap until you get your professorship now no longer exists or is paused for review while they work out how much funding there might be. So it means that if you don't have a contingency, it's not a safe environment to necessarily work in, and you need to think really carefully about if it's a career that makes sense for you. In addition, working in Thailand, I'm really lucky that I work here with some fantastic community organizations and community groups. But with the funding here from the US being so unpredictable and much of it being cut, it's very difficult to do really community engaged research because you don't know if the organizations that you're working with are going to have capacity to collaborate. You don't know if people are going to lose their job. And I think it speaks to a larger issue with maintaining research infrastructure for the HIV response, where we're losing a lot of expertise. I'm sure we all know of really fantastic colleagues that have gone to other fields because it's too unpredictable now. So I think that's my main reflection.
Great, thanks so much. And Dan?
Yes, first of all, I would like to take this opportunity for the organizers of this symposium for inviting us to share our stories. And we could vividly remember the stories because it all happened almost a year ago, this month, where everything was dropped like a hot potato, where we had to change everything. And that's also what happened in the Philippines. In our organizations, and in all community-based organizations in the Philippines, we are somehow in a better setting in terms of service delivery because HIV testing, prevention, specifically PrEP, and the antiretroviral treatment is actually provided by the Philippine government. But in terms of the sudden increase of the cases, rise in HIV cases that we're experiencing in the Philippines, where there's an increase in 500% of number of cases comparing 10 years ago, that would mean that even though we have the means for us to deliver the services, that would mean that it would take us another level of innovation, another level of improving our services, and that was killed by these funding cuts. Our capability and that enabling environment for us to innovate, to introduce services, to reach out to the key populations that we haven't reached, erasure of the transgender identity. There's so many things that we communities are caught off guard. And I remember sharing a conversation with some community-based organizations worldwide, and we are all in agreement that we haven't really had a good night's sleep since January of last year. It is because we don't know what's coming next. And it is such a testament that health services are deeply impacted by political decisions. And if you're a type of person who can influence everything at the blink of an eye and change the world in a different setting, it will impact the work that we are already providing. We are so lucky in our organization in Love Yourself that we are able to think 5 years ahead, 10 years ahead, that we need to diversify and think of other strategies for us to continue the work that we're doing. Because we, as a developing country, we also recognize the fact that development partners and other governments will not be supporting us all the time. But we had to activate those. Our 5-year plan ahead, we had to activate it all at once so that we won't giving job cuts to our staff. We won't be reducing our capability for our volunteers to help the community. So we had to activate those strategies so that we'll able to continue our services. But I shared the same pain that Rina mentioned in the conduct of researches. We are, as a community-based organization that's mostly reaching key populations, definitely most of our researches are, in terms of its inclusion criteria, are mostly reaching key populations. We had to change terminologies as well. Our government sometimes are asking us, are you not reaching transgender women anymore in your research? Oh, we're all reaching men. With a wink. Saying a signal that we do reach them, but we cannot say them out loud. And there is a conflicting sense in ourselves that we can say that everything in our research we're all reaching men, but we know for ourselves that these are our friends, our people that we are erasing in these researches, and that is a difficult conflict that we are experiencing up to now. So definitely, I'm very sure that many people are saying that, okay, community should be the one rising up again to ensure that we fight for these budget cuts to find solutions and advocate for better services. Yes, we definitely are advocating for the government to step up, but we are also communities. We are eternally tired, even up to now. And if we don't have the resources also to support our advocacy efforts, we will not be able to fight. So I guess that's really the impact of budget cuts. It's not really the biomedical services, but also it has a psychosocial impact on how we do our work as communities.
Great, thank you. Well, I think we've heard some really interesting perspectives across the board from in some cases, service delivery, as we heard here in Bangkok. In several cases, community-led response, which is where the community really does rely on this additional funding. Impacts on training and the future workforce in global health, not just in high-income countries, but also in low and middle-income countries, and then direct effects on clinical trials. So these are quite extensive, and we haven't really even touched on so many other cuts that have happened in research. And some of the strategies that people have used are interesting, and I think, Dan, you highlighted a really important issue, that the silencing is very damaging to us as a community, and really unacceptable. We need to think of a name that can escape. We need AI to develop a name that can escape the AI, but perhaps key populations in and of itself is enough, because we know who that includes. I'm going to ask the panel now to just briefly talk about whether in this era that we've now been painted, they can see some opportunities for change. And certainly across Africa, there's a lot of discussions about countries now wanting to see a different model for global health that's not led out of the US, but is locally led. And certainly in Africa, certain countries, South Africa, Nigeria and others, have increased local funding for HIV, not to the level that was being received from the US government, but still increasing. There's a lot of coordination across Africa through the African CDC, WHO, etc. A little bit harder in Asia, I think, which is a bit more fragmented with country-by-country response, which was one of the unique challenges we have here in identifying opportunities for new models of global health and the HIV response. But maybe if I just ask you for 2 minutes each, so that we have some time to go to the audience of whether you might see any opportunities. And we might start with you, Raina.
Oh, okay, just grab the mic. So he's just grabbing the mic. I thought you wanted to speak. It gave me some relief. Okay, I'll make this quick. And I guess one thing that I've always been thinking about is before we rebuild. Like I think this is like the AIDS 2026 like tagline. The first word is rethink, right? If I'm correct. Like and before we rebuild the same like building after the earthquake, should that building be there? Like when the building is there, you can't just demolish it and then like build something else. But now that has happened, like does the architecture change, right? And I think I think a lot about that. I think a lot about how like funding sometimes also shapes outcomes. And like if I draw on my own experiences, sometimes funding makes like our local organizations in Singapore go towards a certain direction that does not serve communities as well. I mean, that's not to say that funding isn't life-saving. Funding is necessary. It's just that because of the change in funding, like whether it's at the national level, like rethinking, where power lies, where funding lies. Maybe at the regional level, looking at the global health architecture, maybe more regional collaborations and resource distribution. And also, I think from a very solidarity perspective, right? Because it's so easy for a country like Singapore to be a neo-colonial or neo-imperial kind of like power, to kind of like step in and say we want to do things. But like if that happens, it also leads me to think about a few things, right? At this point in time, why would I need an organization like Love Yourself or like let's say Tangerine Clinic to give me a research proposal before I give them funding? I think about conditional and unconditional cash transfers, and the science behind that. When you give people conditions, it warps things. When you give them money unconditionally, they're not gonna like spend it on like gambling and drugs and everything else, right? They're gonna use it for things that serve their needs and the communities that that they serve, right? So I think rethinking these kinds of things as well. Like what grants ask communities to do, what shapes outcomes. We don't have to start from scratch. We already have trusted partners and trusted communities working in this area. So how does that look like in the future?
Okay, yes, so to respond to Sharon's question about the opportunities, yes, of course. I think after we have experienced the funding cuts on HIV in the at the beginning of last year, I think it actually opens the new window opportunity for us to explore more on women's health. Right now, we are doing a lot of research around sexual health and reproductive health and rights among cisgender women, which we just realized that when we looked at the data from our clinic, that cisgender women, especially young cisgender women, they are also have the STI burden, which has been out of attention of the National AIDS Program before, because they were not considered as part of the HIV key populations in the past 10 years. So now I think it's really give us the special focus on looking at the women's health in general, and we are able to explore more work around STIs, syphilis, chlamydia, gonorrhea, or even Mpox, as well as mental health area as well, because we really believe that, we are not working directly to HIV, but this kind of, other social determinants of health, they also contribute to the vulnerability of HIV anyway. So right now we are also working to explore the new area around suicidal prevention among young populations in general. So I think it's give us the one of the lessons learned as well, that you cannot think about HIV alone, but you have to integrate other health aspect or other social aspect if you want to bring the HIV epidemic down. And another opportunity that we learn is that we have to look at the domestic funding resources as well, because I think Thailand has been in a position that we do not actually rely so much on the external funding when it comes to HIV, because the HIV funding in the past mostly, rely on supporting the community-led response. So right now, I think the question is that how the country's government has to take up this responsibility to sustain the community-led response in HIV program, because they have proven that, half of the HIV testing among key population also coming from the community-led clinics across the countries. Yes.
Maybe Dan, do you want to build on that, on an opportunity, because it's probably connected, and then we'll go to Maria.
Yeah.
And just for 2 minutes, so we've got some time for the audience.
Okay. Yeah. Aside from building opportunities on exploring other options aside from HIV, I guess that's one route that we also had explored in the organization, to foray into primary care in response to the universal healthcare law that was applied in the Philippines, where we now address NCDs, hypertension, diabetes, and this opportunity comes now for us to promote our services, not only about sexual health, transgender health, and mental health services, but also exploring opportunity for you to really take care of your overall health and wellness. So I guess that's one route that we explored in our organization for us to ensure that we don't really rely on HIV alone. I think one key element that communities should need to learn now is how to diversify our resources and ensure that in diversification of these resources, we also aim for sustainability in everything that we do. Because we're not only providing services, we do evidence-based advocacy, and we also ensure that we can do all the advocacy efforts that we are doing if we have all the resources that we could gather from our diversified portfolio. So I guess that's really one route where communities can go through, is to explore how they can intensify efforts to ensure that their resources are well equipped so that they could give more to the community. So I guess that's one route that we also explored as an organization.
Great. Yes, Maria.
So, unfortunately, the funding for clinical research has been greatly dominated by the global north. So maybe the global south this is an opportunity for the global south to step up and collaborate more. So we've actually been looking with Australian collaborators, because most of our collaborators in the organization are mainly US collaborators. So we've also are looking at collaborations within Europe. So so we are able to continue the clinical research, and of course in-region collaboration would be maybe pooling of government funds to do academic research, because most of the academic research that we're doing are mainly funded by the NIH. And yeah, so these venues and domestic fundings from foundations, we've also looked at that, and we actually saw one call in country that is calling for health equity research. And in country, unfortunately, our research fund is only 0.14 of GDP. So it's an opportunity for us local researchers to also encourage the government to increase the budget for research.
Great, thank you. And Charles?
So I think for me, the biggest opportunity that this funding situation gives us is to rethink the tools that we have in the toolbox. So I recently did, so a lot of my research looks at how HIV, mental health, and substance use are interconnected, and how negative outcomes in all of those areas are intertwined. I recently did a systematic sort of scoping review, finding all the HIV, mental health, sexual health, and substance use interventions that were implemented in Southeast Asia for GBMSM since 2010. In this, we found 149 interventions. Of those, only 4 were focused on mental health primarily. And of those 4, 2 actually looked at the impact of HIV treatment on people's mental health outcomes. We also only found 2 that were specifically focused on substance use. There were some other studies that had secondary outcomes in mental health and substance use, but really we don't have a lot of evidence about effective approaches in addressing these, which we know also impact HIV outcomes. We also know that particularly for the group I work with, GBMSM who use drugs in sexual settings, HIV is not their main concern. It's often about trying to use substances more safely, dealing with police violence, supporting their own mental health, and supporting those areas is a good way to get people into HIV prevention or care services, similar to what Reina was talking about with providing gender-affirming care. And I think this new paradigm that we're in gives us the opportunity to think about how we address people's needs holistically, how we listen to communities and put them at the center rather than take direction from our funders in terms of these are the outcomes that our funders are interested in, and then designing interventions around that.
Great, excellent points. We now have about 15 minutes for people to ask questions. If you have a question for the panel, please proceed to one of the microphones in the aisle, introduce yourself, and please tell us who your question is directed to. Iskandar.
Me? No. Can you hear me?
Yeah.
Right.
Yes, we can.
Hi, I'm Iskandar from University Malaya. I just wanted to ask, several points were mentioned, but no responses really. So, and maybe a question addressed back to you, Reina, and as well to you, Sharon. I mean, certainly there were opportunities for Australia and other high-income countries within the region to step up. So not just Singapore, Japan, but certainly I think for some time people were looking towards Australia. So how has that fared, and is that still a possible avenue as an opportunity, not necessarily to fill in? I mean, the US were providing a major amount of funding, but even a small percentage that would have been helpful, I think. That's my first question. I've got 2 other questions.
Yeah, maybe I'll respond to that. It's a very good point. And I must admit, back in January, when this was all happening, or February, that was my immediate response. Like, Australia has to step up and spend more money and fill the gap. And we haven't seen that. however, they are, because we face the same challenges as what we heard from Charles about other countries also reducing overseas aid. But, my view is also stepping up in research investments too, because we haven't even touched on the level of investment that the NIH provides in developing new drugs, new vaccines, cure research, all the things that we want to see in the future for HIV comes, 90% of it to date is largely funded by the US. That was my initial response. Although I was taken aback by another narrative, which was we need a different model, that it doesn't all come from high-income countries. I think that is still relevant. And I do think we need regional strengthening across a very diverse region like the Asia-Pacific region, and whether something innovative, a new funding model could happen at a regional level. I should say the areas that Australia would likely invest more in is in areas, and Australia is a government that is voted in to look after its citizens. So they're very worried about biosecurity. They're very worried about influenza. They're very worried about polio in the region. They're very worried about surveillance that was previously funded by the WHO. And the US retreat from the WHO is really only going to be felt in the coming year. And so I think that may be one area that the Australian government will step up. The other area, I just make one final comment, is in the HIV outbreak in Fiji. So we saw in your presentation, Fiji has got the second biggest growing HIV outbreak currently, second to the Philippines. And Australia has now committed considerable funding and resources to work with the Fijian government, which I think previously the CDC may have stepped in there. You have some other questions?
The second question to Rena. Undoubtedly some community-led models and provision of services have been affected by the funding. But yesterday we had a very empowered primary care physician, the vice president of the, the Family Medicine Specialist Association, who was very interested in provision of HIV prevention services. It is also an opportunity to engage them. I know a lot of communities within Thailand and in the Philippines have, issues with clinicians, particularly primary care or infectious disease physicians. But it's an opportunity. I understand that primary care services in Thailand are not very empowered, but it's an opportunity to change that. And it can start with HIV prevention. And I just wanted to know what your thoughts are on that.
Yes, I think you're right, Prof. Iskandar. I think right now the community-led clinics in Thailand, after the recent US funding cut, they have adapted themselves by working towards more on becoming a social enterprise in order to generate incomes from clients who are able or willing to pay for the services, but they do not want to go or to pay higher at the private hospitals. And one of the strategies to become a social enterprise is that they have to become a medical clinics, which require them to have a full-time physicians to come to work with them as part of the medical clinics to become a social enterprise. So I think almost all of the community-led clinic right now, they have registered themselves and they have the full-time doctor or specialist to work with them as a full-time in order to make sure that they can generate more income, and in order to not only to providing services to Thai clients, but also to non-Thai as well, because we're seeing lots of non-Thai clients traveling or seasonal tourists coming for PrEP, for PEP, or even ARV refills as well. Yeah, so I think that's another strategies that I've learned.
And just a final question, if that's okay. Malaysia, and particularly Malaysian AIDS Council, where I work also with, and I've mentioned this to a couple of you before, has been fortunately very successful at engaging private funds. And there was and I know a lot of this is around academia, but maybe you could mention, have you looked towards private funding? I mean, I always mention, somebody keeps on mentioning, why don't you approach the guy who owns King Power for funding, or the equivalent of, and so we have a lot of funding from government-linked companies. It took time, but it gradually built up, but 1/3 of it is, of the funding within Malaysian AIDS Council is from private government, from government-linked companies, as well as the banking industry as part of their, corporate CSR responsibility.
Yeah. David?
Yes, I think I can answer that question. I agree that private partnerships would really benefit communities, especially if there are companies that have their corporate social responsibility projects in their respective companies, which in benefit gives them tax breaks. In our organization in the Philippines, we have explored organizing events that will enable pledges to support community initiatives. We did one last December. It's called Love Gala. It was actually organized by Miss Universe 2015 Pia Wurtzbach, and that enabled funding for us to support youth initiatives in Love Yourself, where large companies, where Pia is actually endorsing, like a banking company, a large cosmetics company, and other multi-international companies also pledge their support to enable support. So I agree that private partnerships actually gives us another avenue for us to enable the support that we need for us to do not only advocacy efforts, but also in-turn service delivery. I would also want to echo what Rina mentioned in terms of exploring social enterprise, because this is one opportunity also where the communities can explore, because not everyone would want free services. If they have the capacity to pay, they can have that capacity to pay. But I think we should be guiding communities on how to set up these systems, because not everyone are well equipped to set up systems, even with private partnerships that will require certificate of donations and all of these regulatory details, which I think communities would be needing support for that.
And Raymond? Wanted to add to that?
No, I was going to say that in Singapore, I think that's the only model that we've ever used, right? Because a lot of times we have to, a mix of social enterprise, pay what you can for communities. A lot of, recently I attended the Action for AIDS gala, and I became $2,000 poorer myself, because, every seat was $1,000, right? And it was about 100 seats, so it's like $100,000 for one night's dinner, right? And you get, so it's like a lot of models like that. And fundraising is like a huge thing that we try and teach and build capacity in like communities here. But of course, it's also a mix of social contracting for the government, a mix of social enterprise. But yeah, I think we also need government support, because for new charities, they also tend to do like a $1 to $1 matching in Singapore. So I think there's a whole ecosystem there that probably needs to be built up as well.
Yeah, it's a very good point about leverage. More governments now really like leverage to extend their reach of their budgets. But we have another question here at the front.
This might not be as good of a question because I'm a resident and I'm not ID trained or global health trained. So a lot of this has kind of gone over my head. But my name's Megan, I'm from Georgetown University. I'm a third-year medicine resident, so I've rotated at the NIH, and a lot of this is really great to hear, because we get to see like what the NIH does within the US, but we don't get to see the impact that it has outside of the US. And I'm here on like a global health rotation at a local hospital. I was wondering if you had anything that, I know it's hard to get jobs, as you were saying, in global health now because there's decreased funding, but if you're interested in global health, is there something you would recommend people interested to apply for, or specific like charities that do still have funding?
Charles, maybe take that.
I think if you're interested in global health right now as an academic job, it's a good idea to get a job that's not necessarily in global health and then build up a side portfolio that is. So when I transitioned into working and living in Thailand, I was working with a group that was focused on doing research in the UK. And over time, I slowly built up my portfolio of grants to do work over here as well. So if you're working in an academic setting, you can often run small grants on the side, and it's a good way to get a taste for it, see if it suits you, see if it's an avenue you want to explore, and then build up from there. That would be sort of my biggest recommendation for if you're trying to make a move.
Yeah, I think it might be worth adding that, of course, the US government's not the only funder. You know, the Gates Foundation have recently announced that they're doubling the speed at which they're going to, that Bill Gates wants to give away his fortune. We have the Novo Nordisk Foundation from Denmark, a brand new, very large entity that's focusing on global health. Of course, the Wellcome Trust, other, philanthropic donors, other governments that still invest in global health training. So I don't think you should be disillusioned at all. And I think the need is there, and so opportunities will be there as well. It's just that there's been this the big shift, I think, is uncertainty and change. And I think Maria made a good point that you had all this change and then it was reinstituted again. You might want to just share that with the audience before we wrap up.
Yes, it was reinstituted, but then, of course, as you know, the funding cycle is 7 years, and then the next cycle, we don't really know how many international sites they will be getting. So you really have to be innovative in your sustainability to be able to maintain your staff. So that's the main issue now, is the uncertainty in the future.
Now, before I ask you to join me in thanking our panel, I'm going to announce that the next panel will follow on immediately. There won't be a coffee break, so we'll move straight on to the next panel at 2:30. So if you please don't leave the room, and coffee break will be after that at 3:30. I think we've had a great discussion. I guess the main point is, whatever you're feeling, you're not alone. Many people are feeling the same way as you across the world. And you can see that there really is a whole lot of new ideas about ways things might differ going forward, new ways to innovate in what we know and what we do already, new funding opportunities, new partnerships.